Hi everyone, and welcome to Trauma-Informed Care, Recovery-Oriented Care, Correlated and Complementary, our next webcast on Trauma-Informed Care. We're going to give everybody about 2 minutes just to get into the room and get settled. While you're coming in, please feel free to answer the poll questions that you can see kind of below and to the side here, and we'll get started in just about a minute. Hi everyone, we'll be getting started in just about a minute. All right, well, welcome everyone to the Trauma-Informed Care, Recovery-Oriented Care, Correlated and Complementary webcast. Today we're going to be focusing on the overlap between Trauma-Informed Care and Recovery-Oriented Care. My name is Katie Volk. I am your host, and today we're joined by Rebecca Miller from the Department of Psychiatry at Yale School of Medicine. If you haven't already, take a moment to answer the questions in the chat box below. Just so we can get a sense of who is here. And those questions are, where do you work? What do you already know about trauma-informed care? And what population do you primarily serve? In a moment here, we are going to switch over, and you won't be able to see the poll questions anymore, but there will be a chat box where you can ask questions throughout the webcast. We mute all participant lines so that background noise is to a minimum. But the chat box is a great way to ask questions. I'll also say that this webcast is being hosted by the New England Mental Health Technology Transfer Center, MHTTC, and the Great Lakes MHTTC. The New England region and the Great Lakes region have partnered together to bring this all to you. We are focused in our respective regions, so both New England and in Great Lakes, on working to convene people in our regions to figure out what the needs of the behavioral health workforce is, and then provide connections and provide training and technical assistance within those areas. This is the second in a series on trauma-informed care and part of a bigger series on evidence-based practices that we're offering. Everything is being recorded today, and we'll archive it on our website as well. So it looks like we've got many of you work in other fields. So when we get to the chat box, let's type, if you all don't mind typing in where you work in those other fields, because it looks about 70% of you are in other fields. So I'm very interested to know where that is. And it looks like some of you know a little bit about trauma-informed care, which is fantastic. And most of you are working with adults, so it looks like a lot of people working with co-occurring disorders, some other, and then some working with specific populations. Wonderful. So let's see. If you are using the computer audio, please mute your speakers so that we don't hear background noise. Like I said, this is being recorded and there'll be a chat box. If you have any questions after the webinar, you can email us at newengland@mhttcnetwork.org, and I'll put that address up at the end of the webcast as well. So what I'd like to do now is switch out of the polls over to the main webcast series. I'm going to hand things over to Rebecca to introduce herself and walk us through today's content. Thanks, Rebecca.
Great. Thank you, Katie. Thanks so much for inviting me. I'm really excited to talk to everybody today about recovery-oriented care and trauma-informed care and how they overlap and how they complement each other. So let me introduce myself first. I'm a clinical psychologist. I work at the Connecticut Mental Health Center, which is in New Haven, Connecticut, and it's a collaboration between the State Department of Mental Health and Addiction Services and the Yale School of Medicine Department of Psychiatry. I direct peer support services here and also am very involved in teaching psychology interns, psychiatry fellows, and other staff. Just to say that I would love to have you ask questions during while I'm talking, and we'll try and incorporate those as they relate to the topic areas. So please feel free to type in questions as we're going. I'd love for this to be as interactive as possible. And especially since many of you know a good deal about trauma-informed care already, to really have you chime in and give your perspective as well. So as you can see, the learning objectives, we're going to just briefly review the key values of trauma-informed care, differentiate between trauma-informed care and trauma-specific services, and then talk about recovery-oriented care and how that relates to trauma-informed care. So, So I want to start out just by kind of grounding us today in what Pat Deegan, who's a psychologist who has a diagnosis of schizophrenia, calls a leadership story. So coming back to why you got into this work and why you continue to do it. Sometimes we can get very stressed out, high rates of burnout, et cetera. And so just remembering where that drive to do this kind of work came from. So this is a picture of my daughter, Cece. This is a couple years old. She's 6 now. But one of the reasons that I am involved in this work is if she ever needs to use the mental health system, I want it to be as person-centered, as trauma-informed as it can be for her. So I identify as a person with lived experience of mental illness myself. I also have a diagnosis of Parkinson's disease. So if you see me moving a little bit, differently, that may be the reason. So just to let you know that. But I have my own experience with the mental health system that had its good points and its not so good points, and I would like it to be the best for her if she ever needs to use it. So take just a couple, couple seconds and think back for yourself. What drew you into this work and what keeps you here? So keeping that in mind, I want to talk a little bit about recovery. And I would love to know how many folks are familiar with the concept of recovery. It's been around since the early 90s now in the field of mental health, emerging out of the addictions world, but also very different in the sense that it's really focused on how people with serious mental illness can live a full life while still experiencing symptoms, while still, dealing with mental illness. This is SAMHSA, the Substance Abuse and Mental Health Services Administration's most recent definition of recovery. And interestingly, mental health is not even included in the definition, but it's really about how people can improve their overall health and wellness to live a self-directed life and to reach their full potential. So really trying to move from a more medical deficit-focused model to one that's focused on recovery. So, oftentimes when we think of recovery in a more physical health setting, we might equate it with cure. And that's not what is necessarily meant by recovery. So it doesn't necessarily mean that someone is stabilized and maintaining in the community per se. It's really about not just surviving, but how do we help people thrive? How do we help people work towards the best life that they can live in the community of their choice? So this is, again, Pat Deegan, and obviously a fan, but talking about the transformation of the self, where, it may not be that you, go back to what you were before experiencing mental illness. It may really change the trajectory of your life, but doing, pursuing your life goals and doing what you want to do in your life as best you can while, managing or living beyond the symptoms of mental illness. So it's also more related to a disability model where it's about finding the, keys to help you manage whatever symptoms are distressing you at the moment. So there's an apocryphal story about a man who heard really loud voices, and he would talk back to them. And so this was embarrassing to him, so he, didn't want to go out, didn't want to go to work. And so someone came up with the idea of giving him a cell phone that didn't actually work, but that he could put up to his ear when he was hearing the voices, and he could scream into the cell phone. So one day he was on the train, and everyone was jabbering away on their cell phones, talking, until the train went through a tunnel. And so everyone stopped talking because there was no reception in the tunnel. But he continued on and suddenly realized that he had been revealed to not have a real cell phone. He was humiliated, he was embarrassed. He leapt off at the next stop, went running down the platform, only to have a number of guys chasing after him. And when they caught up with him, they said, "What service do you have? What service do you have?" So just to say that it's being creative and finding ways to help support people in living their best life in the community. So, similar to someone with a physical disability might need to use crutches or a wheelchair, et cetera, that's sort of one of the principles of recovery and recovery-oriented care. So SAMHSA identifies 4 dimensions of recovery. So health, and this is really the only one where they specifically mention any kind of disease, illness, etc. So how to manage and overcome what you're experiencing, what the person is experiencing with mental illness, a stable and safe place to live. And I like that in this language they use home as opposed to housing. So housing can sometimes feel more clinical or distancing in a way, but really it's about how do you find a home where you feel comfortable. And again, that relates to the experiences of trauma and the fundamental aspect of safety, so a stable and safe place to live. Purpose, some meaningful daily activities. This is so important for all of us to feel like we're contributing and that we are somehow giving back. So oftentimes there's a critique of the word, the term consumer. And one of the critiques of that by people with experience of mental illness is that it feels like it's characterizing them as only people who take and consume, as opposed to how does the person also give back. One of the studies done by Michael Rowe, who's at the Yale Program for Recovery and Community Health, a group that I'm affiliated with, did a survey of folks who had experienced mental illness, and that actually giving back came up as a more important to folks who experienced mental illness as compared to groups of folks who had not. So that is something to keep in mind, is how can you facilitate and create opportunities for folks to get back so that they can work to develop that sense of purpose. And then community, relationships, social networks, et cetera. All new research is coming out about the effects of loneliness and how loneliness can be as negatively impactful on health as smoking or heart disease. So really helping people and supporting people and finding those friendships. So when we talk about trauma, just exposure in the general population is so high, and somehow this slide is showing up on my screen is slightly black, but it's 43 to 92% are the ranges of incidence in the general population for men. And then, let me just double check this, and 36 to 87%. So studies show a range, but at the high end, that's, just about everyone has experienced some kind of exposure to trauma. In the public mental health system, 90% exposed to at least one traumatic event and 43% diagnosable with PTSD. So oftentimes this is multiple traumatic events, and oftentimes folks end up being re-traumatized. And then I think it's so important for us to remember and consider the experiences of trauma within the mental health system. So many of the folks that we work with, I know have been in the mental health system long enough to experience things like cold packing or insulin shock therapy, treatments that we now see as not only ineffective but not ethical, but that folks have experienced these kinds of things from the mental health system. So there's a term for this called sanctuary harm. So within a place where people expect to be taken care of, that is actually a place that ends up being hurtful or harmful. As well, coercion within the mental health system, seclusion and restraint. We know that, although particularly efforts around trauma-informed care have worked to reduce the incidences of seclusion and restraint, I know in this building where I work that still does take place much more rarely, but that it still does happen, and it is extremely traumatizing, especially for folks who have had a history of sexual assault or rape. So that's really important to keep in mind, especially for folks you find difficult to engage. Maybe they aren't coming into appointments, so it might be that the actual building itself, is triggering us to their past traumas, or the fear that, sort of that fear that if they say the wrong thing, that they'll end up being hospitalized. So that's really important to just keep in mind and acknowledge. There's a recent study that came out that indicated that folks who had been coerced felt more coercion in terms of being hospitalized, had a higher risk of suicide post-hospitalization. So it's not just that we want to avoid coercion for kind of some philosophical value, but that it's also can be potentially a risk factor for death. So yes, witnessing any of these events, but actually, as far as I know, the public mental health events do not include vicarious trauma. Sorry, there's a question that came in about, Jay was asking, do these statistics include vicarious trauma? So I would have to go back to the general population studies and look at those. I'm not sure. That's a great question. And that's especially important for those of us working in the mental health system. We know that listening to people's experiences of trauma can be vicariously traumatizing. So, and all of us as treatment providers, and many providers have their own experiences with mental illness, or but that we also are likely, just having lived on this earth for a certain number of years, to have experienced some kind of trauma. And I have a colleague who says we're all in recovery from something. So, whether it be heart disease, smoking, any kind of experience that we felt we kind of need to recover and take back our lives and get back on track. So using your empathy and analogizing experiences in a certain kind of way. Not to say, oh, I know just how you feel, right? That phrase meant to be kind of make a connection with someone can actually end up feeling invalidating. So kind of avoiding that, but how can you kind of work to better understand someone's experience by relating it to your own? So just to review the values of trauma-informed care. So safety, trustworthiness, choice, collaboration, and empowerment. And safety is really the fundamental, foundational piece and is what traumatic experiences really disrupt that sense of being safe and okay in the world. So just to share with you that we, several years back, we did a trauma-informed care initiative here at CMHC trying to implement these principles. And I'll show you one of the things that we created was this, it's coming out of nowhere, but this sign called Safe Zone. So trying to indicate to folks who are LGBTQ that that this is a place that you can feel safe to share your identity and be your full self. And that this was one way of indicating this in a very kind of visual, concrete way. And I think that's one of the things that really appeals to me about trauma-informed care in general, is that it looks at all aspects of safety, trustworthiness, all of these values. So there were so many environmental changes that we made here at our center to try and be more trauma-informed and trauma-sensitive. For example, when you walk down the hallways, you can't necessarily see who's coming in the opposite hallway. So we installed mirrors so you could look up in the mirror and see who was coming towards you. We had very, very poor signage. So I worked in an office that was 517, and there was another office, 517, that was 3 doors down. So talk about kind of crazy making, experiences where you have 2 offices with the same number. So things like that, because we were built, this building was built in 1966, so it's gone through a number of renovations, et cetera, but just paying attention to those details and how they help to create a sense of safety or to create a sense that you're not safe. So that's a really important consideration. And the other piece that I just want to say about trauma-informed care is looking not just at as clients or people receiving services, but it's looking at the whole system. So it's not saying that we're going to provide these services to folks who are coming to us who've been traumatized, but to say we've all likely had experiences of trauma. How can we pay attention to these values for all of us? I once heard a sort of provocative phrase said that if you don't feed the staff, they eat the patients. Now that sounds a little drastic, but it's to say if the staff, if you as a provider, staff that you're supervising don't feel cared for, nurtured, and safe, that it's going to end up affecting the care that you can provide for the people you serve. So this is where I sort of take from more infectious disease, the idea of universal precautions. So this was, originally I think this came with the HIV, rise of HIV, that it used to be that you only wore gloves for folks that you knew had some kind of transmittable disease. And then it moved towards universal precautions where you assume everyone might have something and you universally prepare for it. So in the same way, assuming that everyone in your workplace, clients and staff alike, have had some experience with trauma, and making these values important to implement and adhere to. And transforming, this is a kind of fundamental question when thinking about the folks that we work with. From what's wrong with a person to what's happened to this person. So this is sort of jumped ahead a little bit, but trauma-informed care includes looking at policies, procedures, physical environment, staff relationships, hierarchy in the organization. So do staff feel heard when they have a concern about safety, or do they feel like they have choice in their job roles? Do they feel empowered to bring something that they feel needs to be changed to the administration, for example? And then also assessing trauma in those receiving services, addressing trauma, and providing often gender-specific services to treat trauma. So I just want to take a pause and see if there are any questions or thoughts or other examples that you have from your organization before we move on. So just to talk briefly about trauma-specific intervention. So I think this is often when people hear trauma-informed care, they jump to the specific treatments for trauma, which there, thankfully are a number of different treatments that have been found to be effective. I'm not going to sort of go through the research on each of these today, but and you probably have knowledge of some, if not all of these, but these all fit under the umbrella of a range of services that should be offered in a recovery-oriented care system. So some of these include the Trauma Recovery Empowerment Model, or MTREM, which is the same curriculum but designed specifically for men, Seeking Safety, prolonged exposure therapy, EMDR. So these are really geared towards clients who have a significant experience with trauma, and these are services to provide for them. I also would, in my mind, include EBP as a trauma-specific intervention. So often folks that we work with who benefit from DBT or who have been diagnosed with borderline personality disorder also have complex trauma, so long histories of trauma, often in childhood. And there's been a move to actually rename borderline personality disorder as complex trauma, although that has not been taken up yet. But that is often that many of the behaviors, symptoms, and patterns are in response to severe trauma, and can, when seen in that way, can be seen as attempts to be effective that may have been effective in the past but are no longer working for the person. So overlaps with recovery-oriented care. So I'm going to first give a metaphor about recovery versus recovery-oriented care. So I see recovery as sort of analogous to exercise. So I cannot have anyone else exercise for me. As much as I would love that and really appreciate it, you would do it for me, because exercise is probably one of my least favorite things to do, but it's only something that I can do myself. So so that is recovery for me, and that recovery is something that the person needs to take responsibility for and work towards. A recovery-oriented care system is one that, with the analogy of exercise, provides the sneakers, the gym membership, the workout buddy, the videos on different exercises, the kind of motivational support, all to help support the person in doing the exercise themselves. But that, similar to recovery, the person has to do it themselves. So so that's just an analogy for recovery versus recovery-oriented care. And I would say when comparing recovery-oriented care to trauma-informed care, both are really focusing on the process and the journey, not the label. Not a diagnosis, but how do we create a space that will support a person in moving forward in their journey. Both are really strength-focused. When you think about looking at what has helped this person make their way through despite these traumatic experiences. Similarly, recovery-oriented care looks at what strengths can the person draw upon to move forward towards their goals. So in some ways, trauma-informed care and trauma-specific services are looking at kind of restoring a past experience. And recovery-oriented care is in some ways more focused on how the person is going to move forward and pursue their hopes and dreams while living with, in spite of the barriers, which may include symptoms of ongoing mental illness or addiction. So really, so instead of looking at what are your problems that we can fix and seeing a kind of deficit approach and making a problem list, what are your hopes and dreams for the future, and how can we help you overcome the things that are getting in the way? So, and this is also relates to person-centered care, which you may have had training on, and developing a recovery plan or a treatment plan that is goal-oriented rather than deficit-oriented. So that's a key practice in recovery-oriented care. And that person-centered plan would then include those trauma-specific services as a way to help the person overcome those barriers. So, if the person is struggling with nightmares and can't get to sleep and therefore too tired to actually go to work, which is really important to them, this is where trauma-specific services can help address those nightmares, along with other services potentially, to support the person in either getting a job or continuing to keep the job that they have. Okay, I think I was getting a little silly with this. I was thinking of the a Jackson 5 song, ABC. But just putting trauma-informed care and recovery-oriented care side by side. So recovery is looking at an individual's journey and path, and it's keeping those principles in mind. So some of the core principles of recovery include focusing on hope, helping to instill hope in the person, as I was saying, strength-based, and trauma-specific services focus on addressing trauma specifically, and trauma-informed is keeping those principles and those values in mind for all the kinds of decisions that we make. So when looking at something like choice as one of the key trauma-informed values, when you look at something like a psychiatric advance directive or a PAD or a RAP plan, which is a recovery, wellness recovery action plan, those are really emphasizing choice for the person. Those are, recovery-oriented practices, and provide the opportunity for the person to really, in advance, make some clear decisions about how they want their care to go, even in the case of them being unable to communicate those decisions themselves. So, for example, I'll share a personal story that when I was 19, I became psychotic and could not communicate. So I could not share what I wanted, and I ended up being taken to the ER by coworkers, and then when I wouldn't go to sleep, I was taken to a unit, and when I wouldn't go to sleep, the problem was I couldn't communicate why. So I didn't want to wake up my roommate who I hadn't met. So I wouldn't go into my room to go to sleep. And the staff members were intent on me going to sleep. And so that point where I was unable to communicate resulted in me being restrained and involuntarily medicated. Now, if there was some way that I could have in advance specified my wishes and desires, and sort of a hyper-specific example, but hopefully you can get the idea from it, that maybe that wouldn't have happened. So, for example, now I have my own document of treatment preference, which is from RAP, that says exactly what I want to happen if I become in that state again where I'm unable to communicate my wants and needs. So I basically became mute and was unable to speak. So now I have, my psychiatrist that I work with, my therapist that I work with, have this that outlines specifically, these are medications I'm willing to take and these are medications I'm not willing to take. Under this circumstance, I would be willing to have ECT. Really making those specific needs and wants very clear. And I think that ends up being an empowering document in that I know that I've really spelled them out to people. Now, fingers crossed that actually gets honored and used, and there's still some legal hurdles in terms of enforcing things like psychiatric advance directives. But I think even just creating that and feeling like you actually have a choice as to what might happen. So that's one of the examples. So here's my daughter a little bit older. So trauma can leave us upside down. Psychosis can leave us unable to trust our minds. And systems can leave us burnt out. This is really the importance of recognizing, how these systems affect us and affect all of us. So it's so key to keep these values in mind in all that we do. I like this quote from Mary Oliver. Someone I love gave me a box full of darkness. It took me years to understand that this too was a gift. So this is, again, thinking about the transformation of traumatic experiences into something that people can actually draw strength and draw value and transform them into something useful. So, I'm able to take what were very terrible experiences to me and use them for teaching and to hopefully help transform the mental health system to be more recovery-oriented and trauma-informed. So how can you support those that you work with in really starting to see these things as potential gifts? Peer support is one of those great examples of people taking those kind of either humiliating or embarrassing or traumatic experiences and transforming them into something that is useful and helpful and can allow them to give back to others. So I just want to go a little bit further into looking at the move from traditional mental health care to recovery-oriented, and then linking some of these values to trauma-informed care. So traditionally, a focus was on stability. All right, so how can we get someone back to baseline? But with a recovery-oriented approach, it's really about hope for the future and how can we help the person thrive. So Pat Deegan has a quote about, sitting in her apartment and waiting for the mythical chemical balance, right? That, that this message that was sometimes given about avoiding stress so that you don't, develop symptoms again can actually be something that holds us back. Because, pursuing important goals is stressful, but it's a stress that we can learn how to manage because those goals are important to us. So really, identifying the values and the hopes and dreams for the person and then helping them to pursue it. So traditionally we talk about compliance, whether this be around medication or compliance with treatment recommendations. And it sort of gives a sense that, in one sense, it's compliance is saying like you're following the directions. In another sense, it gives this idea that we, as a mental health system, are, want to have people follow along regardless of what they think. So kind of breeding sheep. And so really transforming this into thinking about choice. So when thinking about language to describe someone who is traditionally called non-compliant with medications, instead you can rephrase that to say they choose not to use medications as part of their recovery. So it can sound a little Pollyannish or euphemistic at first, but it's really indicating that that person is making a choice, whether we agree with it, whether we feel like it's an informed choice or a positive decision for themselves, that's kind of another matter. But the fact that they are making a choice and to help them feel more in control. Now, this next traditional approach is controlling and having control over someone and moving instead towards partnership. And this relates to the trauma-informed care value of collaboration. So how can we implement principles of shared decision-making, really provide decision support so that a person can really look at what are the possible choices and outcomes and working with their doctor, with their provider to partner with them around making life decisions or treatment decisions, etc. We talked about the deficits versus strengths, low expectations versus high expectations. So, this is really holding out the confidence in someone that they can do what they hope to do. I think, again, oftentimes, traditionally in the mental health system, people were given the message that they should give up their hopes of working, of having a family, of having children, those things that we all as human beings hope for. And even if someone has a very serious history or a long-standing experience of homelessness or other kind of seemingly, history that is hard to overcome, really having the expectation that they can do it. And this is also related to what a former colleague of mine, Priscilla Ridgway, called the duper mentality. So doing for someone as opposed to doing with or teaching or supporting someone in doing for themselves. So if you are holding high expectations that a person can actually do this themselves, then you are kind of helping them build their confidence and self-esteem, as opposed to giving them a message that they, because of mental illness or their experiences, that they are more helpless. And that relates to the next item. So learned helplessness or victim. This is sort of has been one of the legacies of the mental health system and institutionalization in general for a number of different conditions. But really, how do we encourage active participation? And then supporting risk, and again, the meaningful life is the goal as opposed to stabilization. So how can we help the person not just survive, but thrive? So being person-centered, not looking at people through the lens of diagnosis necessarily, but what do all people need? Love, purpose, home, etc. Those kind of values that Sam's identified. And then specifically, what does the person sitting in front of you really want? And using that to kind of guide the care and the treatment. So, wrapping up, addressing trauma. It's a key element of recovery-oriented systems. I think that has been increasingly adopted throughout systems. and really emphasized in recent years. Not necessarily as much in the initial stages of implementing recovery-oriented approaches, but more and more it's recognized, and research really demonstrates what an impact trauma has on all of us, but specifically the higher rates for those in the public mental health system. And then moving from a medical model to a disability model, a rehabilitation model, or a strengths-based model, and really looking at how do we help people adapt to and work with their symptoms or limitations or barriers to move towards their goals. And then more and more focus on the impact of trauma, ACEs, the context on mental health disorders. So I'm going to stop there and open it up to some questions. Would love to hear your thoughts, comments, whether if there are disagreements or experiences you've had in your organization. I'm going to step away for 1 second from the computer and just get myself some water. So I'll be right back. So I'll just say, while waiting for questions to come in, that it was amazing in our implementation of trauma-informed care, how we were doing it in collaboration with a number of organizations around the state, and so many had a focus on their parking lots and their parking lots not feeling safe, which was really striking to me, and yet such an important aspect when you're coming to work and or leaving work and you don't feel comfortable kind of on that walk to your car. And that's where trauma-informed care can get really into the kind of nitty-gritty, concrete details, but that are so important, both to staff and then also when talking about patient care.
So I can see, this is Katie Volk. I can see people typing some questions into the chat box there. I'll just want to say I really appreciate, Rebecca, your focus on both the treatment side of things, but also on the environment, because I think that's so often the piece that gets missed,
Mm-hmm.
You have to have both, right? Safe environments and safe surroundings, and the other piece of it.
Yeah, it's so important. I mean, something as simple as what they call wayfinding, so being able to find your way in the building. And, for all of us, when we go into a new environment and we're sort of feeling lost and it leaves us feeling vulnerable, when there's good signage and clear signage, it really leaves you feeling more comfortable and more safe. So I remember going to Bellevue Hospital for a tour, and they had these colored lines painted on the floor with, indicating within the line, this way to the ER. So you basically follow the color green all the way till you get to the ER. And it was so comforting. I mean, it sort of seemed, maybe a little like kindergarten, but it really just left you feeling like, okay, I know where I'm going. I can feel more comfortable in getting there. Especially, I know for us, we at the Community Mental Health Center, our director says we see people at probably the worst moment in their lives, that they are feeling in such distress that they're coming to see us, and how do we help them feel as comfortable as possible when they get here. So Beverly had a question. Thinking of the person in the social environment, culturalisms of all kinds, vast inequality, climate change, mass migration, war. I felt that in my social work practice, that the forest gets lost for the trees. Mm. So sort of, I'm wondering, Beverly, can you say a little bit more about that? I'm not sure that I'm quite, that it's sort of the bigger picture is missed when we focus on the smaller pieces. I'm thinking that's what you're referring to, and I think that the impact of all those social right, like all those social movements or things like climate change cause a degree of existential distress in all of us, and that it doesn't really, it's not easily addressable through our individual work. I know there's a increasing focus in psychology and psychology training on advocacy and advocacy work for social change, because it can feel like oftentimes we're asking the individual to adjust to a technical term, a messed up environment, right? Sort of like, we'll give you, on like a very micro example, oh, you're depressed because you're in an abusive relationship. Well, we'll give you antidepressants so you don't feel those symptoms, as opposed to looking at the, the system, the relationship that's actually contributing to this. And I think you're saying on a much larger scale that all of these kind of social problems and have an impact on us, and that I think that it can leave us feeling somewhat helpless, and that there is a place and a role, I think, increasingly for us as practitioners to get more involved with larger scale advocacy efforts. One, because it's, otherwise we're just sucking babies from the stream, right? I don't know if folks are familiar with that story of, that there are all these babies coming down a stream or a river, and we keep plucking them out and saving them, but who is throwing the babies in the river? And so really that can be, feel like a kind of, very frustrating position to be in. And if there's some way to get involved with looking at that upstream process to focus more on prevention. I know when the community mental health movement just started in the 60s and 70s, there was an intention to really have funding go more towards prevention and have that be a big part of the community mental health movement, and that was unfortunately did not get as much funding and as much focus as I think it could have. So, great comment.
So I can see a few more comments coming. I'm just going to scroll to the next page while those comments are coming in to say that if you'd like to get in touch with Great Lakes or New England, MHTTC, these are the email addresses, and I put mine there as well. I also wanted to say that this is one webcast in a series that we're doing on trauma-informed care, with the idea that this is leading up to us running a learning collaborative for programs that are interested in implementing trauma-informed care in their environment. And so if you'd like to take a look at that application, it's on our website. And here's that. We have our next webcast is July 10th, and that'll focus on a quick snapshot of what it looks like to implement trauma-informed care. But you can look, you can register for those on our websites, and you can also get the Learning Collaborative application. And if you have any questions at all, certainly get in touch with us. The Learning Collaborative will really focus on working with a team of people from various organizations to kind of look at policies, procedures, services, things like that through a trauma-informed lens, with the idea that you leave the Learning Collaborative with a strategic plan for how to implement trauma-informed care throughout your program or your organization.
Yeah, and I really encourage people to apply. That is one of the ways that I learned about trauma-informed care and that we've implemented in our organization, and it is really eye-opening. I know one of the projects we did here was a secret shopper experience where we had someone unknown to us go through our intake procedures, go through, that initial walking in the door and give us feedback, and with kind of that, eye towards whether things are trauma-informed, what are our assessments like, what are our questions, how friendly are people. When you call the organization, you get, good directions to come, all those kinds of things, and that's really helpful. And I think just to comment also on one of the things that I think is really important about trauma-informed care as a principle is that it is sort of equalizing, and that its approach is that the assumption that we've all experienced some kind of trauma, and therefore these principles are important for all of us. So it kind of breaks down in some ways that us, them, piece that can feel more salient in mental health, where it's, we are serving the clients, kind of trying to bring us all together around this shared importance of paying attention to trauma and how we can make our services more trauma sensitive.
Yeah,
So
thank
are
you.
there any last questions or comments? So my contact info is on the slide. Please feel free to get in touch if you have any questions or thoughts. I'd love to hear from you.
Rebecca, I just want to say thank you so much for taking the time to talk with us today. I really appreciated all your examples and the conversation. This webcast has been recorded and will be archived on our website. You'll also all be receiving an email with an evaluation link, so please go ahead and fill that out when you get it. And if you're interested in continuing education, there'll be you do get credit for the webcast. You'll just have to answer a couple of knowledge questions, and those will be embedded in that survey that you get for evaluation purposes. Thanks, everybody.
Thank you.